Let's review the types of hypersensitivity responses in clinical settings. And this includes when drugs act as antigens or allergens to the immune system. So this applies to immunogenicity responses. Type 1 hypersensitivity is a typical hypersensitivity or allergic reaction that can occur with food allergies, allergic rhinitis, bee stings, pollens, dog dander, and it's all beautifully painted by Monet. Type 1 hypersensitivity is an allergic response that depends on IgE. And Caravaggio presents a beautiful fruit basket that carries a lot of potential allergens. So with this allergen is presented to the B cell will process it and in turn present the specific T cell epitope that differentiates the T cell into a Th2 with mainly production of interleukin-4 that will produce the differentiation of the B cells into memory B cell and plasma cell, most importantly, with eventually the production of IgE. IgE is critical for all allergic responses, and it's the one that characterizes the type 1 hypersensitivity. Why IgE? IgE is recognized by the mast cells that carry the IgE receptor. And when this IgE is bound to the allergen or the drug that's immunogenic, the mast cell will have an effect on smooth muscles, blood vessels, mucous glands, platelets, sensory nerve endings, and eosinophils. This produces a typical allergic reaction with sneezing, itching, pain, edema, swelling, and it can be really fast. The reaction could be 5 to 30 minutes. The manifestations could be anywhere from mild to severe manifestations, and they are basically wherever the allergen or the drug that's immunogenic has been encountered by the body, either respiratory or GI or the skin. There's a lot of edema and swelling. Now, while the majority of the allergic reactions could be mild, they can also be life-threatening. Type 1 hypersensitivity anaphylaxis is lethal, and it should be treated appropriately. This is a painting of Ophelia, who was gathering wildflowers, and who knows, she may have actually died of type 1 hypersensitivity anaphylactic reaction. Type 2 hypersensitivity reaction now requires tissue-specific antigens and the production of IgG. What this means is that whenever there's a cell surface receptor and the allergen or the drug that's immunogenic binds to that cell surface, we now have a tissue-specific antigen. And when the body reacts with production of IgG, this IgG will activate the complement. This complement activation eventually recruits MAC, who's not of Scottish descent, is the membrane attack complex. And this will destroy the cell that's bearing the allergen or the drug that's immunogenic. This is called antibody and complement-mediated destruction because it requires the IgG and it requires the activation of the complement system. And it's not unusual to see it. We have the autoimmune hemolytic anemia. This is the way that the red blood cells are destroyed, but probably the one that's better known is the incompatibility of blood types when there's a blood transfusion that is not matched. This is the way that the antibodies from the patient are going to react to the red blood cells that are being transfused because they do bear an antigen that is not known to the recipient of the transplant. And in good pasture syndrome, what is being recognized is basically on the kidney. So these are different examples of type 2 hypersensitivity. Of the first one that we will review, it's the one that's complement activation. Type 2 hypersensitivity which again we have the surface antigen and the IgG. In this case, with the antibody that engages the antigen on the surface, produces the expression of the complement with C3 expression on the surface of the target cell. This recruits macrophages, which cause phagocytosis. So this is another way that an antibody binding the surface antigen will produce killing of the target cell. And again, this can happen, for instance, in the incompatibility of the rhesus type blood group when the mother is negative and the child bears the rhesus antigen on the red blood cells. The mother antibodies will cross the placenta and produce the destruction of the red blood cells in the babies. This is mediated by antibodies. And the third subtype of type 2 hypersensitivity reaction, again, requires the surface expression and IgG, and in this case, when the antibody binds the allergen or the drug that's immunogenic on the surface, it will recruit peripheral blood mononuclear cells. These cells bear the Fc receptor, and that engages the IgG, and this will directly stimulate these cells into producing granzymes. These enzymes destroy the target cell. This particular reaction is relatively common because IgG is a very prominent antibody that we could produce against either drugs or allergens after a first exposure, especially in this type 2 hypersensitivity. And this is the way that we normally deal, for instance, with intracellular parasites or with neoplasms. It is called antibody-dependent cell cytotoxicity because it entirely depends on having an antibody and engaging the Fc receptor of the effector cells into producing the enzymes that kill the target cell. Now, this can also occur in drug immunogenicity, for instance, with epoetin. Epoetin will be a growth factor that stimulates red blood cells, but if the patient develops antibodies to the drug that are bound to the red blood cells, it can cause pure red cell anemia. And one of the potential problems with this is if the antibodies of the patient cross-react with the natural epoetin, then this is a condition that's called in-cross reactivity, and it would be a serious adverse event of treatment with endogenous proteins. This is just one example, but it could potentially occur with your biologics that are endogenous proteins. Drugs as haptens also use this mechanism to produce the hypersensitivity type 2, and finally a lot of drug-induced anemia, thrombocytopenia, or neutropenia. So in this case, it is very important you understand what is the target cell of the drug that you are using for your patients. And if you understand what is the target cell, you can see if the reaction the patient is presenting with may be due to an immunogenic response to the drug. In this case, type 2 hypersensitivity. Type 3 hypersensitivity requires the formation of immune complex. And it can be with IgM or IgG. Again, these are antibodies that the individual will be producing to the allergen or to the drug that's immunogenic. So in these complexes, what happens is that the allergen or the drug will be bound by several molecules of the antibodies from the patient, and they produce complexes that deposit on different tissues. This will engage or activate the complement that attracts neutrophils that express the Fc portion in the case of IgG immune complexes. But both IgG and IgM can activate the complement system, especially with other products that will recruit the mast cells, and these are primarily responsible for the signs and symptoms. They carry a huge amount of histamine, serotonin, serine proteases. All of these are enzymes that will destroy the tissues where the immune complexes are deposited. But furthermore, it can also produce heparin, for instance, and this will make the blood flow faster and distribute widely in the tissues that are being attacked. And it produces necrosis. Locally, we have the Arthur's reaction, for instance, with the smallpox vaccine. The pigeon's breeder's disease, which will happen in the lungs, that's where you would have the necrosis, celiac disease in the gut, or insect venoms, basically could happen on the skin. The problem is that this could become systemic, and we have typically serum sickness, lupus glomerulonephritis. When these immune complexes are deposited in the kidney, they are carried in the blood and deposited in the kidney. In rheumatoid arthritis, where the immune complexes will actually eventually find their way into the joints and cartilage, and of course with chondroitin sulfate proteoglycans destroy the joints, and also some other types of animal venom. This can be mild, but it can also be serious. The difference is this will take time to develop. So these signs could manifest even weeks or sometimes even months, like in lupus or rheumatoid arthritis. They may take time to develop. So in the types of hypersensitivity, we have type 1. Anaphylaxis requires the presence of IgE. It is a very fast response, usually 5 to 30 minutes you start on noticing the symptoms. Type 2 requires tissue-specific antigens and IgG. Type 3 requires immune complex formation, and it will be less acute manifestation. It could be within days or even months after the exposure to the allergen or the drug that is immunogenic. All of these require the presence of antibodies, and it's what we call humoral mediated immune responses. They require B-cell activation. Type 4 hypersensitivity is T-cell mediated, and basically what we have is both the T helper cells Th1 and Th17, these are CD4s, or CD8 cytotoxic T cells. In this case, there's no antibody formation. Type 4 hypersensitivity is cell-mediated immune response. The cells that have the allergen or the drug that's immunogenic will be presenting it to the dendritic cell that migrates to the lymph nodes, engages the T cells, and with the appropriate co-stimulation will differentiate the T cell into a Th1 that will activate macrophage responses, or Th17 that will recruit neutrophils. It is the macrophage and the neutrophil, the one that produces the damage onto the tissue that is carrying the allergen or the drug that's immunogenic. So these Th1 and Th17 responses are CD4, and they're also called delayed type hypersensitivity, or DTH. It does take time for the dendritic cell to migrate to the lymph node, to present with the appropriate co-stimulation to the T cell, differentiate them, and then bring back those target cells into the presence with the macrophages or the neutrophils. So this takes time. When I say time, it could be days to weeks. This is a typical response we have to poison ivy. Some patients develop the response weeks after they have been out in the woods or in contact with the poison ivy, and some others can develop it within 3 or 4 days. Of course, the PPD, which is a tuberculin skin diagnosis for tuberculosis, and it's a DTH reaction, and contact dermatitis. These are all examples of CD4-mediated DTH. On the other hand, the dendritic cell could actually migrate again to the lymph node, and in this case activate CD8 cytotoxic T cells. It will not be producing a T helper response, but directly a CTL or cytotoxic T cell response, whereby the CD8 cells directly migrate back, identify the cells that carry the antigen or the drug that's immunogenic and destroy them. This response is typical in type 1 diabetes, and by the way, this has been reported with antibodies, therapeutic antibodies to the CD3 surface antigen of T cells. So this drug is used in some cases for treatment of cancers, but it could activate this cytotoxic T cells and produce type 1 diabetes as an adverse event. In rheumatoid arthritis, this is also another type of hypersensitivity that we see, and graft rejection. The types of hypersensitivity reaction are type 1, very typically characterized by the presence of IgE, and it's a typical allergy and anaphylactic reaction. Type 2, that is tissue-specific antigens where IgG will bind, and there's 3 different types. One of them is complement dependent because the IgG activates the complement. The other one is antibody-mediated phagocytosis, where the IgG binding to the cell surface stimulates macrophages. And finally, the antibody-dependent cell cytotoxicity, where the IgG bound to the cell surface will actually be engaged by the Fc receptor of effector cells that kill the target cell. So these 3 belong to the type 2 tissue-specific antigen hypersensitivity, characterized by the presence of IgG. Type 3 requires the presence of immune complexes that could be IgG or IgM. Now, all of these antibodies, IgE, the IgG or the IgG and IgM, are produced by the individual, by the patient. So it's an idiosyncratic response. We don't know what the patient is going to develop in response to an allergen or to a drug that's immunogenic. But what these 3 types of hypersensitivity have in common is the presence of antibodies, and it's what we understand or call humoral-mediated immune response driven by the B cells. Type 4 hypersensitivity is a T cell mediated response where there's not going to be antibodies to the allergen or the drug if we're talking about immunogenicity. It's basically T cells that could be of the helper type, type 1 and type 17 helper cells, or it could be the CD8 cytotoxic T cells, the ones producing the response either to an allergen or to a drug that's immunogenic. The Samson criteria are an approach to evaluating anaphylactic events, and this is encouraged to be used specifically when we're looking at therapeutic drugs as antigens for potential immunogenic response to drugs. But it can be used in the clinic, and it's actually extremely useful in the setting, for instance, of an emergency room. The Sampson criteria were published first in 2005. There is a follow-up paper, 2006. The criteria remain basically the same. And these are extremely useful. From the paper, it quotes, anaphylaxis is highly likely when any one of the following 3 criteria are fulfilled. And the key importance of this is, remember that anaphylactic reactions are life-threatening. So let's take a look at them in a bit more detail. The first criterion tells us that the patient presents with an acute onset of an illness that involves the skin, mucosal tissue, or both. There's examples of the kind of manifestations this means. So in here, we are in the presence, let's say in an emergency room, or a patient's given a history of an acute involvement of the skin. They do not know, do not remember, or cannot tell us if they have been exposed to an allergen. So that's why it's very important. Criterion number 1 is actually agnostic to the potential allergen or the drug that could be immunogenic. It's extremely useful when we do not have the complete history but we have a presentation in the emergency room. Besides having the skin or mucosal tissue manifestations, there has to be at least one of the following, which includes respiratory compromise or reduced blood pressure or any symptom or signs of end organ dysfunction. So this is very important. The patient is coming with shock. The patient is coming with incontinence, wheezing, bronchospasm, and they also have some sort of skin or mucosal tissue. This is an emergency. It has to be considered an anaphylactic reaction, even when the potential allergen is unknown, and the patient has to be treated accordingly. Let's look at criterion number 2. In criterion number 2, 2 or more of the following should occur rapidly after the exposure to a likely allergen for that patient. Why am I saying this? Well, the patient is giving a history of having had a reaction to a particular drug, and they may not have known that they were getting the same drug with a different name. Or they know that they are allergic to bee stings and they got stung by a bee. So when there's a likely allergen for that patient and the patient can provide the medical history, any two of these two is going to be making the diagnosis of anaphylaxis for quick treatment response. The first one is the skin mucosal tissue. Second one is respiratory compromise. The third one is the reduced blood pressure. All three were components of criterion number 1. And now we also have a persistence of gastrointestinal symptoms, which are particularly seen with food allergies. And so patient knows that they cannot eat some sort of a shellfish or seafood and they are exposed to it. They will be having the symptoms, and any two of these 4 criterion plus the medical history makes this highly likely to be anaphylaxis and should be treated as an emergency. Criterion number 3 is now just reduced blood pressure. That's all we know when a patient comes having been exposed to a known allergen for that patient. And when I say allergen, it also applies to immunogenic drugs. So if a patient actually is known to be allergic or to have an immunogenicity response to a particular drug, and they present as infants or children with low systolic blood pressure, or as adults with a change in blood pressure that's as defined, 30% decrease from the patient's baseline or less than 90 millimeters of mercury in the systolic blood pressure, this is indicative of anaphylaxis, again, importantly, with the history of the patient. So with the Samson criteria, criterion number 1, when we cannot obtain a reliable history, but we have any one of these symptoms that the criteria is listed and patient should be treated. Number 2, when we can obtain medical history and it's a likely allergen for that patient. And number 3, when it's a known allergen for that patient. Please do not wait to get any laboratory results to treat these symptoms. They are very quickly developed. It's a very fast response and they could be lethal. So you might have confirmation of IgE levels after you treated the patient, but do not wait for IgE levels to make sure that you make the diagnosis of an anaphylactic reaction. The recommended references are attached, and I hope you enjoy and subscribe to my channel. Thank you.